Hi, everyone, and welcome to this very exciting and clinically relevant symposium entitled Take It to Heart, Managing Cardiovascular Risk in People Living with HIV. First, let me thank Merck and CAHR for organizing this great program. My name is Cécile Tremblay. I'm professor in microbiology, immunology, and infectious disease at University of Montreal, and I will be your moderator. As some of you know, I've been involved in understanding the pathogenesis of premature aging phenotypes with the Canadian HIV and aging cohort for the last 10 years. This cohort is now led by Dr. Madeleine Durand in Montreal. We're looking at biomarkers that could help predict those events. So today we have the privilege of having two great speakers who will address some of the determinants of cardiovascular disease in people living with HIV. The first one is Dr. Greg Bondy. He is a clinical assistant professor of medicine and pathology at the University of British Columbia and a member of the Division of Endocrinology in the Department of Medicine at St. Paul's Hospital. Dr. Bondy earned his MD from the University of Toronto and did his postdoctoral training at the University of Western Ontario. He was a member of the Department of Medicine at McGill University Royal Victoria Hospital before moving to Vancouver. As many of you have seen him over the last decade, Dr. Bondy's research and clinical interests include dyslipidemia, type 2 diabetes, and metabolic abnormalities associated with HIV therapy. Our second speaker will be Dr. Jacques Jeannette. He's professor of medicine and holds the McGill Novartis Chair in Medicine at McGill University. He has been the Cardiac Care Unit Director at MUCH for the past 4 years. Dr. Jeannette obtained his MD at McGill University, then went on to do a cardiology fellowship at Tufts University in Boston. From 2000 to 2010, he was head of the cardiology department at McGill University and the director of the Center for Innovative Medicine at MUCH from 2010 to 2014. His research focuses on the metabolic and genetic basis of premature coronary artery disease and the role of high-density lipoproteins in atherosclerosis. He has been involved in the design and conduct of several large clinical trials, including Jupiter, Reveal, Improve It, and has published over 350 peer-reviewed manuscripts in high-impact journals. For the past 25 years, he has participated in the elaboration of the Canadian cholesterol guidelines. So I hope you will enjoy the presentations from these two highly regarded experts, and I look forward to talking to you during the Q&A period. Good conference.
It is my pleasure to be giving you a presentation this afternoon. My name is Greg Bondy. I'm an endocrinologist based at St. Paul's Hospital. For the last 20 plus years, I've been managing complications related to HIV, and I've been invited to talk to you for the next 20 minutes about weight gain associated with HIV, the good, the bad, and the ugly. So my apologies to spaghetti westerns. Here's my disclosures. I speak mainly for diabetes companies and lipid-lowering agents. I am being paid by Merck today for this talk. Objectives are very straightforward. I'm going to talk about HIV body fat redistribution, but I'm going to spend most of my time talking about antiviral trials and the weight gain that's been noted to be associated with those trials. Very briefly, we'll look at treatment options. The weight gain, what is the good? Well, as this slide shows, unfortunately, we don't see this as much anymore, but if you present with wasting, meaning advanced HIV, going on an antiviral is actually associated with good outcomes when you gain weight. Conversely, if you don't respond to the antivirals and you continue to lose weight, you're going to have an adverse outcome. So there is good news from a weight standpoint, when you go on antivirals, generally that means you're doing a lot better. And there's a number of reasons for this. They're all been lumped under return to health. So you get diminished inflammation. The body is no longer catabolic. And in terms of different organ systems, certainly in the GI tract, you got diminished opportunistic infections. You're able to actually absorb nutrients. So what's the bad about weight gain? Well, as this slide shows, here's people with HIV grouped to being underweight, normal, overweight, and obese. And the amount of weight you gain after going on antivirals is related to where you start at. So predictably, people who are underweight will gain the most weight, whereas people who are already obese, the curve is relatively flat. So the issue is when you gain weight, and we're going to talk about how much weight you do gain on antivirals, is visceral obesity itself. Here's a slide that's over 20 plus years. It's from Dr. Dupre in Quebec City. And basically, it shows here as your gut goes out, there's a variety of biochemical markers that change. You get the elevated triglycerides, low HDL. You get predominantly small, dense particles. If you looked at inflammatory markers, you'd see as your gut goes out, your inflammatory markers go up. On the other side, you'll have elevated insulin levels, which translates into insulin resistance. And the end point is you're going to develop endothelial dysfunction. So gut obesity is really associated with a whole bunch of metabolic issues. And this slide is just meant to remind you that the fat is just not a simple storage organ. It's been very surprising how many metabolic processes go on with fat cells. They release a whole variety of hormones, and we're only beginning just to understand those signaling. But certainly, inflammation is one of the key components. So what's the ugly about weight gain in HIV? Well, this is an old slide. I had to pull out my archives, but when we first started to use highly active antiviral therapy, a select number of individuals, I'd have to estimate about 5% of people treated, would develop profound body fat redistribution. This individual is showing a really big cervical hump. The interesting thing about this hump is he had it liposuction and it grew back within 6 months. Unfortunately, we don't see this much anymore. This slide is meant to show you the various body fat redistribution that has been described in HIV. As described earlier, you'll develop fat gain in your gut. You can get it in your cervical neck. You can get it in your breasts. You can get it in a variety of different areas. You can lose fat. So early on in the treatment of HIV with these various drugs, it was noted that people began to lose fat in their face, arms, and legs. This subsequently was shown to be primarily due to mitochondrial toxicity. And individuals would often show both features, gain of fat, loss of fat. Now, fortunately, we don't see this anywhere nearly as much as we used to see 30 years ago. In fact, the main issue we see nowadays is weight gain with visceral fat accumulation. So, what is the clinical significance of weight gain associated with integrases and antivirals? Well, to get a handle on that, there's been a number of key papers that have come out in the last year or so. This is Paul Sachs' paper, and it gives us some very good information regarding contemporary antiviral therapies and associated weight gain. And in this particular cohort, which was 85% men and probably 60% whites, you can see when you go on antivirals, you gain weight. And as you can see at 144 weeks, the typical weight gain in this particular cohort was close to 3.5 kilos. I'm going to show you more data on this as we go on. And that is a feature that's really become associated with antiviral therapy currently. Now, the other thing that this study showed is the following. Basically, there was a sex difference. Females gained more weight than men. And in terms of races, blacks gained the most. And then predictably, the individuals who had the most weight gain were black females. Now, this slide breaks it down according to the antiviral agent. As you can see, integrase inhibitors were the ones that were most associated with weight gain. And as you can see, the risk ratio was 3.2. In terms of the integrases themselves, it was associated with the more modern integrases, specifically Biktarvy and dolutegravir. Now, the other antivirals were also identified. Here's the non-nukes. Certainly, ripivirine has more weight gain compared to efavirenz. And very interestingly, when you look at the nuclease reverse transcriptase inhibitors, TAF, which has obviously taken over the market, was associated with weight gain. And I don't think anybody predicted that that was the association they were going to see, but certainly TAF has more weight gains, certainly than tenofovir. Now, the next question is, when you have this weight gain, does it really lead to any metabolic consequences? Well, again, you have to remember, this is a trial, or I shouldn't say a trial, a data set that was in a relatively young cohort over a relatively short period of time. So there was, on average, close to 4 kilogram weight gain. That did not lead to a change in fasting glucose. LDL cholesterol and triglycerides increase, but incredibly to a small amount, on the order of 0.1 millimole, okay? HDL, there was a very tiny increase, but for all intents and purposes, it really didn't change that much. And the ratio, again, was slightly better, or slightly higher, I should say, in the people who had gained weight. And then last but not least, there was no change in blood pressure. So these are all features that you typically associate with weight gain, but in this particular cohort over a relatively short period of time, it really didn't lead to significant metabolic changes. And to summarize Sachs's paper, is basically there was a strong association with weight gain and advanced antiviral disease. So again, the return to health phenomenon. And when then you broke it down, the newer antivirals are very much more tolerable, but they did lead to weight gain. And that weight gain has been linked to a number of different factors, like better tolerability. Perhaps you could spin it that you got better virological control. And then some people look mechanistically, but the data for that is still fairly soft. Now, PrEP gives us some insights into, is it HIV or the drugs themselves? Well, of course, PrEP is in individuals who are not infected with HIV. And there's a number of trials that have used different agents. And certainly when you look at tenofovir, you actually had weight loss. Basically, that's led to the fact that perhaps tenofovir itself has some effect on body weight, i.e. it induces weight loss. Certainly, TAF, when you compare it to tenofovir, leads to weight gain. What about other studies? Well, the ADVANCE trial is a very straightforward study done in Africa, predominantly Blacks, very simple design. One arm was traditional agents, efavirenz and tenofovir. The other two arms were dolutegravir, one with tenofovir, the other with TAF. And as you can see on this slide, when you looked at the three different groups, there was weight gain in the individuals taking efavirenz and tenofovir. The weight gain at the end of the trial period was 2.3 kilos. The greatest weight gain was associated with TAF with dolutegravir. In this case, the average weight gain was 7.1 kilos. And when you looked at the advanced trial, again, the individuals who are most prone to gaining weight were women. And again, they're predominantly Black women. And as you can see with the blue bar, on average at 96 weeks, they were gaining 9 kilograms in weight gain. Obviously a great concern. And just to complete antivirals studies and weight gain, here's from CAHR2021. This is Workowski's work. Again, these are treatment-naive adults, 4-year outcomes on Biktarvy. And as you can see, the weight gain was quite consistent. They gained in the first year close to 4 kilos, and with each subsequent year, you would gain another kilogram. So in terms of antiviral therapy and body weight, weight gain is a very common finding in individuals going on antiviral therapy. There are individual and disease-specific factors that are likely linked to more weight gain. I alluded to those. Obviously, sex, meaning females, and race, meaning Blacks, are associated with more weight gain. In terms of the antivirals themselves, the integrase inhibitors, certainly the second generation ones, are associated, but also TAF has been associated with more weight gain. We really don't understand why this is occurring. And again, we go back to statements like lifestyle and exercise need to be emphasized. And with that in mind, I'll really finish off by just describing what you should know about body fat. In terms of skills to measure body fat, the only practical one, in my opinion, is to measure the waist circumference. And I just remind you, there's a specific way to measure waist circumference. You don't put the tape on the belly button because that tends to move around. You need to find your bony landmark, specifically the iliac crest, put your tape measure on there, and then measure it. And that'll give you an accurate measurement of what your waist circumference should be. So in terms of obesity treatment itself, diet is very important. Ketogenic diets are very, very common nowadays. Physical activity continues to be a challenge. Bariatric surgery for morbid obesity is definitely an option. In terms of medications, really, this is what you should remember. Certain medications can make you gain weight. And some of the ones I use, like glucocorticoids, anti-diabetic meds, will do it. But now antivirals will have to join the list of drugs that increase your weight. In terms of anti-obesity drugs, the only real player is the GLP agonist. And in terms of in Canada, the only one that's licensed so far is once a day Saxenda. And if you read the New England Journal about a month ago, you'll see that once a week Ozempic, which is very effective at inducing weight loss, will cause about a 15% weight loss on average in individuals. And I just remind you, GLP agonists are a hormonal therapy. This is the way your gut talks to your pancreas to release insulin and to suppress glucagon. So in summary, body fat redistribution is an important component of treatment of HIV. The main concern is the increase in visceral fat. When you look at the newer antivirals, they generally will affect and increase body weight, especially the newer agents. In terms of treatment of body fat redistribution, lifestyle and GLP agonists are the main components. So I'll end there, and I'd be very happy to answer any of your questions.
Good evening. My name is Jacques Jeannette. I'm a cardiologist at McGill University, and I will discuss the implication of HIV and cardiovascular disease. And I'm going to start again because I can't turn my slide forward. So let's do it again. I'm going to wait to...
It's afternoon when we present, just so you know, Dr.
That's what I meant. Well, good afternoon. My name is Jacques Jeannette. I'm a cardiologist at McGill University, and I'll be discussing the relationship between HIV infection and atherosclerotic cardiovascular disease. These are my conflicts of interest. We're funded by CAHR and FRCP, but I work closely also with CADIS, the Genest in Quebec, and various societies. I do get paid by Merck for this talk. Well, first, I'd like to divide the presentation in two. One is to define what is atherosclerotic cardiovascular disease, the definition, the risk factors, and our treatment guideline that just came out earlier in April 2021. And then discuss the risk of atherosclerotic cardiovascular disease in patients with HIV and the medications that may alter that overall risk. So I'd like to remind you that the heart is perfused by coronary arteries, shown here as the right coronary artery coming from the aorta, a left main, left anterdescending and circumflex coronary artery. And the disease that we're referring to is the gradual buildup of atherosclerosis, which starts by fatty streaks to atheromas to eventually what we call a vulnerable plaque that may suddenly rupture and occlude blood flow. And the consequence of that is lack of oxygen to the distal part of that organ. So in the heart, it's a heart attack. In the brain, it's a stroke. And in the lower extremity, it could lead to gangrene. And unfortunately, that blockage can happen within a few seconds. And we are still working out on how to identify which plaque is vulnerable to rupture and which plaques are much more stable. And we'll discuss that a little bit further. In the world, there's about 17 or 18 million deaths due to myocardial infarction worldwide. In Canada, with a population of 37 million, cardiovascular disease has now become the second cause of death after cancer. And it should be kept in mind that cardiovascular disease used to be #1 cause of death, followed by cancer. But all the efforts that have been invested in prevention, public health, such as smoking cessation, acute care, ambulances, teaching patients to recognize signs of heart attack, have had a real impact in decreasing cardiovascular disease. So prevention and treatment does work. And finally, our guidelines change every 3 to 4 years based on the available evidence. And as we accrue clinical trials, we can adopt and sometimes reject older hypotheses. So guidelines are often a moving target. Cardiovascular disease is understood best in terms of cardiovascular risk factors. And the main one really is increasing age, cigarette smoking. Men get heart disease about 10 years sooner than women, but once women reach menopause, their risk of cardiovascular disease is at least equal to or even more than that of men. High blood pressure, elevated LDL cholesterol, and we'll discuss what is an atherogenic lipoprotein, diabetes, and I will briefly discuss low HDL or the good cholesterol a little bit later. We've learned from our Canadian colleague, Dr. Salim Youssef, in a beautiful study called InterHeart, that these cardiovascular risk factors that I outlined are both qualitatively different, but also present worldwide. So for instance, if you smoke 1 cigarette, 10 cigarettes, or more than 2 packs a day, the risk increases in a linear fashion. The more you smoke, the more you can have heart disease. If we look, for instance, at diabetes, overall, the risk is increased by over 3-fold, and that risk increase is true wherever you are in the world. So the risk factors for cardiovascular disease are universal, and they apply to the Indian or East Asian subcontinent, South America, America, and of course, Europe. If we put all that data together from Dr. Youssef, and we look at this vertical line of unity here, we know that smoking in men and in women, diabetes and hypertension increase risk, but pay attention also to psychological stress and abdominal obesity, whereas a good lifestyle, including fruits, vegetables, exercise, and moderate alcohol intake decreases risk. And you'll notice here that an index of dyslipidemia, which is reflected by the ratio of atherogenic to protective lipoproteins, increases risk. Bear in mind that most of these are heavily influenced by lifestyle. And our first approach in prevention is really to recommend a good lifestyle aimed at diet, exercise, weight reduction, and stress management. Obesity is a big risk factor. We have many ways to measure it, and there is still equipoise or uncertainty on what is the best index. Is it the base body mass index, the waist circumference, the waist to hip ratio? All of these indices show that the patient or the subject has an increased weight, and that is an atherogenic risk factor. When we look at the physiology or the pathophysiology of atherosclerosis, for the past, more than 100 years or so, we've had inflammation, thrombosis, and of course, hypercholesterolemia, and all three play a very important part, often being very intertwined. So far, we've not been able to modulate inflammation very well. We've tried many, many targets, and none as yet survived very solid evidence-based medicine, except maybe for aspirin, but aspirin also interferes with thrombosis. For thrombosis, we have aspirin in primary prevention, but also the antiplatelet agents such as ticagrelor and clopidogrel in patients who have been revascularized. But cholesterol remains probably one of the major modifiable risk factors after cigarette smoking. And here I'd like to remind you that when we measure blood cholesterol, we measure cholesterol in all of these blood particles that include from the bottom the HDL or protective cholesterol, the LDL, a new protein that we've known for many years called lipoprotein A, but also these particles here, which carry mostly triglyceride, but the amount of cholesterol they carry seems to be also highly atherogenic. I'd like to remind you as well that most of plasma cholesterol is in LDL and HDL, and that the rest is present in these triglyceride-rich lipoproteins. However, that proportion increases in patients who are obese or diabetics who have the metabolic syndrome. And that's what we refer to as the non-HDL cholesterol, and is characterized by a total apolipoprotein B level. So in our new guidelines, we're now emphasizing the non-HDL cholesterol as an index of atherogenic lipoproteins or total apolipoprotein B. When I mentioned that about 5 to 10% of plasma is carried in these triglyceride-rich lipoproteins, this is in normal people, but clearly in patients who have hypertriglyceridemia, these particles carry quite a bit of cholesterol, which is highly atherogenic, and we will discuss a bit later how to address that residual risk. Since the late 1980s, when we've had the first statins, it has truly been a revolution in preventive cardiology. So for instance, if we take an individual with a cholesterol of 3.5 millimoles per liter, which is roughly a Canadian average, and we give him a starting dose of statin, we reduce cardiovascular risk by about 21% for each millimole of LDL cholesterol reduction. That initial approach, the low dose statin, has been replaced with the realization that if we optimize the statin dose, we get a further decrease in cardiovascular risk. And that's been extremely well described in very large meta-analysis. So we can reduce risk by as much as a third by optimizing LDL therapy. And if we look at the cumulative data available from the cholesterol treatment trialist, which is an independent group at Oxford looking at all the statin trials, well, we realized that the benefit is far to the left of the line of unity, where we'd expect no effect. And we have a decrease in non-fatal infarct, cardiovascular death, major coronary event, bypass surgery, angioplasty, any coronary vascularization. The only thing that is not changed is hemorrhagic stroke, which has nothing to do with cholesterol. But overall, all the major cardiovascular events are decreased by about 22% for each millimole of LDL reduction. What's interesting is our guidelines, which stated that we should reach an LDL less than 2, show that no matter what is the achieved LDL cholesterol level, the benefit remains exactly the same. So when we talked about targets, this may be a bit outdated, and I will discuss the difference between a target and a threshold to intensify treatment. Perhaps more importantly, if you percolate down this complex slide again, the line of unity here, statin is beneficial to the left and placebo to the right. You'll notice at the bottom that cardiovascular death total are decreased by about 10%. And very, very few interventions nowadays can show that, except perhaps for cigarette smoking cessation. We focused a lot on biomarkers, and the one that we're now focusing on is a well-known protein to many of us called lipoprotein A. And lipoprotein A is basically one LDL particle in yellow, to which is attached a very large protein called ApoA. I've been quite lukewarm in supporting lipoprotein A as a measurable risk factor for 30 years because we had no efficacious way of lowering it, but now we are starting to develop new drugs to lower it. Finally, there's been a lot of talk on the calcium score, which our American colleagues are strongly supporting, and Canada is a little bit more timid, but in middle-aged adult at intermediate risk, a low calcium score may tell the clinician that you don't need to treat aggressively. On the other hand, a high calcium score may be a reason to intensify treatment or to start statin. Clearly, the calcium score is not useful in a high-risk individual, in patients already on statin, and in most low-risk adult patients. So there might be a sweet spot where the calcium score is useful for clinicians. Our screening recommendations are evolving completely according to available evidence, but anybody, any men and women above 40 years of age, but any of these conditions, the presence of atherosclerosis, smokers, diabetes, hypertension, family history of premature disease, but you'll notice these other conditions, erectile dysfunction may be a sign of atherosclerosis, chronic kidney disease, inflammatory disease, family history of dyslipidemia, and importantly for this talk, anyone with HIV should be screened regardless of age. How do we determine risk? Well, we have what is called risk algorithm, and I'll go briefly over the ones we use internationally. The Americans have used the pooled cohort equation or the pooled risk equation. In Canada, we are still using the Framingham risk score. In Europe, they use something called SCORE, which is country adjusted for risk. But please note that all of these risk engines use exactly the same variables, the traditional risk factors, but the outcomes predicted differ. So for instance, in the score, it's cardiovascular death. In the pooled risk equation, it's the hard endpoints of coronary heart death, non-fatal infarct, and stroke. And in Canada, we're a bit more nuanced. The basis for these cohorts is different. So in Europe, it is many cohorts. In America, they've pooled Framingham with a few other cohorts. In Canada, we have kept with Framingham because it's been quite robust. In terms of prevention, we really advise 5 things that the patient should be doing. Smoking cessation would be the first one. The quality of diet with an increase in fruits, vegetable, decreased saturated fat, not total fat, and decreased salt intake, weight reduction, daily exercise, and stress management. Now, the level of evidence we have for each of these interventions is weaker because we cannot do very large diet studies, but they are based on very common sense. The 2021 lipid guidelines suggest that we should use a statin in the following condition. In the primary prevention setting, an LDL above 5, which would be indicative of perhaps a genetic lipid disorder, would warrant statin therapy. In patients with diabetes or chronic kidney disease, above 40 years of age, we would highly recommend statin therapy. And of course, in secondary prevention, any evidence of atherosclerotic cardiovascular disease, myocardial infarction, acute coronary syndrome, stable angina, stroke, TIAs, peripheral vascular disease, or abdominal or aortic aneurysm. So all of these are indicative of the presence of arteriosclerosis, and the patient should be treated accordingly, aggressively with statin. About 8 years ago, the Americans came in with the concept that targets are not supported by evidence, and they are right. Second, statins do lower the risk to the same relative degree, independent of the baseline risk and baseline LDL cholesterol, meaning that if you had a bypass surgery 2 years ago and you're 70 years of age, you get the same relative risk reduction as if you were a 36-year-old man with just a high LDL cholesterol. But the absolute benefit, the people who benefit the most, is obviously in the highest risk patient. And that's why we recommend a targeted approach to the high risk individual. And these, of course, are patients who have established cardiovascular disease, who have diabetes, and who have a high probability of a genetic dyslipidemia. We've also learned that high intensity statin, and that's defined as rosuvastatin 20 or 40, and atorvastatin 40 and 80 milligram, further lowers risk than a low dose statin. And in my view, there should be no place for low dose statin in a patient who can tolerate higher dose statins. Importantly, there's been no randomized clinical trials that are specifically targeted at target. And what we've used in our guidelines is basically the mean achieved LDL cholesterol in the clinical trials. The evidence, I hope to convince you, suggests that the lower LDL cholesterol is the better thing. When we discuss intensifying therapy, we suggest that if the patient has not reached an LDL less than 1.8 millimole per liter in high-risk individual, then we should think of intensifying therapy by either adding another medication such as ezetimibe, optimizing the statin, or in our case of severe hyperlipidemia, adding an inhibitor of PCSK9. Well, what's this based on? Well, I'd like to remind you that at birth, our LDL cholesterol level is far below 1 millimoles per liter. We have very little LDL cholesterol, which increases in life in breastfed individual compared to formula diet. And if you look to the right, if you have a poor lifestyle, this is a key determinant of lifelong LDL cholesterol level. So clearly, environmental factors, especially diet, lack of exercise, has a huge bearing on LDL cholesterol level. What's also interesting is that as we did clinical trials in the past 30 years or so, 40 years, we have lowered the achieved LDL cholesterol goal such that we have lowered our target or threshold in the past 30 years or so. So which medication should we use? Well, in high-risk individual, statin, ezetimibe, PCSK9. I will not discuss inflammation, thrombosis, or diabetes, but all of these are well supported by evidence levels. Now, turning my attention to HIV, there are many factors that increase cardiovascular risk, including the poor lifestyle, social isolation, financial constraint, heavier cigarette smoking, hypertension, stress, and depression. And if we look at many studies, especially the DAD study published more than 18 years ago, half of the patients were cigarette smokers, and there was a lot of patients with hyperlipidemia. This has been replicated more recently with a heavy dose of smoking in patients with HIV in 2011 and a high prevalence of cardiovascular risk factors. So clearly the HIV population is at high risk, and the new medication that have transformed HIV from a death sentence when I trained to a manageable chronic disease now opens the way to the increase in cardiovascular risk in that population. And when we look at the medication, the nucleoside reverse transcriptase inhibitors, some of them may increase cholesterol. The non-NRTIs can have also CNS effects. The protease inhibitors can cause an increase in weight. So the drug therapies used may alter the risk factor profile of the patient, and that needs to be taken into account when taking a decision. So to finish, what our clinical approach is to do a good history and physical exam, to order a non-fasting clinical profile. We recommend to measure lipoprotein A once in a patient's lifestyle, determination of cardiovascular risk, emphasize the importance of lifestyle modification, and discuss the goals of treatment, taking into account the patient's values and preferences. I'll stop at this point and I'll be very happy to answer questions. Thank you.